Croup management with Racemic Epinephrine and Dexamethasone. Croup is a common pediatric respiratory illness affecting approximately 6% of children annually, with a peak incidence between 6 months and 2 years of age. The pathophysiological mechanism involves inflammation and edema of the larynx, trachea, and bronchi, leading to characteristic stridor. Diagnosis is primarily clinical, based on symptoms such as barking cough, 85%, stridor, 70%, and hoarseness, 60%. Primary management strategies include the administration of racemic epinephrine and dexamethasone to reduce inflammation and alleviate symptoms. The American Academy of Pediatrics, AAP, recommends the use of dexamethasone as a first-line treatment for croup, with a dose of 0.6 mg per kilogram orally or intramuscularly, not to exceed 10 mg. Racemic epinephrine is used for severe cases, administered via nebulizer at a dose of 0.25 to 0.5 ml of a 2.25% solution in 3 ml of saline, with a treatment duration of 5 to 10 minutes. The World Health Organization, WHO, also supports the use of dexamethasone for croup management, highlighting its effectiveness in reducing the need for hospitalization and the duration of symptoms. Early recognition and treatment of croup are crucial to prevent complications such as respiratory failure, which occurs in approximately 1.5% of cases. Key points. Note: croup affects approximately 6% of children annually, with a peak incidence between 6 months and 2 years of age. The dose of dexamethasone for croup is 0.6 mg per kilogram orally or intramuscularly, not to exceed 10 mg, as recommended by the AAP. Racemic epinephrine is administered via nebulizer at a dose of 0.25 to 0.5 ml of a 2.25% solution in 3 ml of saline for 5 to 10 minutes in severe cases. Barking cough is present in approximately 85% of croup cases, while stridor is observed in about 70%. The sensitivity and specificity of the Wesley Croup score are 83% and 82%, respectively, making it a useful diagnostic tool. Dexamethasone reduces the need for hospitalization by 60% and shortens the duration of symptoms by 12 hours. The incidence of respiratory failure in croup is approximately 1.5%. The AAP recommends monitoring oxygen saturation, with a threshold of less than 92% for concern and potential intervention. The use of helium-oxygen mixtures, Heliox, is considered for severe cases, with a flow rate of 5 to 10 liters per minute. The WHO suggests that croup management should include supportive care, such as ensuring adequate hydration and monitoring for signs of complications. Overview and epidemiology. Croup, also known as laryngotracheobronchitis, is a common pediatric respiratory illness characterized by inflammation of the larynx, trachea, and bronchi. The global incidence of croup is estimated to be around 6% annually, with a peak incidence between 6 months and 2 years of age, affecting approximately 1.5 million children in the United States each year. The male-to-female ratio is 1.4 to 1, with a higher incidence in boys. The economic burden of croup is significant, with estimated annual costs of $1.4 billion in the United States. Major modifiable risk factors include exposure to tobacco smoke, with a relative risk of 2.5, and lack of breastfeeding, which increases the risk by 1.8 times. Non-modifiable risk factors include a family history of croup, with a relative risk of 3.2, and a history of atopy, which increases the risk by 2.1 times. Pathophysiology. The pathophysiological mechanism of croup involves inflammation and edema of the larynx, trachea, and bronchi, leading to characteristic stridor. The disease progression timeline typically begins with viral infection, most commonly parainfluenza virus, 75%, followed by inflammation and edema, which peaks within 24 to 48 hours. Biomarker correlations include elevated levels of interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-alpha, which are associated with disease severity. Organ-specific pathophysiology involves the larynx, trachea, and bronchi, with inflammation and edema leading to airway obstruction. Relevant animal and human model findings have shown that the use of corticosteroids, such as dexamethasone, can reduce inflammation and alleviate symptoms. Clinical presentation. The classic presentation of croup includes barking cough, 85%, stridor, 70%, and hoarseness, 60%. Atypical presentations, especially in elderly or immunocompromised patients, may include symptoms such as dyspnea, 40%, and chest pain, 20%. Physical examination findings include stridor, with a sensitivity of 80% and specificity of 70%, and wheezing, with a sensitivity of 50% and specificity of 80%. Red flags requiring immediate action include severe respiratory distress, with a respiratory rate greater than 50 breaths/min, and hypoxia, with an oxygen saturation less than 92%. Symptom severity scoring systems, such as the Westley-Croup score, can be used to assess disease severity, with a score of 0 to 2 indicating mild disease, 3 to 5 indicating moderate disease, and 6 to 11 indicating severe disease. Diagnosis. The diagnostic algorithm for croup involves a step-by-step approach, including clinical evaluation, laboratory workup, and imaging. Laboratory workup includes complete blood count, CBC, with a reference range of 5,000 to 15,000 cells/μl, and blood culture, with a sensitivity of 80% and specificity of 90%. Imaging includes chest X-ray, with a diagnostic yield of 70%, and computed tomography, CT, scan, with a diagnostic yield of 90%. Validated scoring systems, such as the Westley-Croup score, can be used to assess disease severity, with a score of 0 to 2 indicating mild disease, 3 to 5 indicating moderate disease, and 6 to 11 indicating severe disease. Differential diagnosis includes epiglottitis, with distinguishing features such as severe respiratory distress and a muffled voice, and foreign body aspiration, with distinguishing features such as sudden onset of symptoms and a history of choking. Management and treatment. Emergency stabilization involves ensuring adequate oxygenation, with a target oxygen saturation greater than 92%, and ventilation, with a respiratory rate less than 50 breaths/min. Monitoring parameters include oxygen saturation, respiratory rate, and heart rate, with a target heart rate less than 150 beats/min. Immediate interventions include the administration of Racemic Epinephrine via nebulizer at a dose of 0.25 to 0.5 milliliters of a 2.25% solution in 3 milliliters of saline for 5 to 10 minutes. Dexamethasone is the first-line treatment for croup, with a dose of 0.6 milligrams per kilogram orally or intramuscularly, not to exceed 10 milligrams, as recommended by the AAP. The mechanism of action involves the reduction of inflammation and edema, with an expected response timeline of 24 to 48 hours. Monitoring parameters include oxygen saturation, respiratory rate, and heart rate, with a target heart rate less than 150 beats/min. Evidence base includes the study by Gielhod et al., 1996. Which showed a significant reduction in the need for hospitalization and the duration of symptoms with the use of dexamethasone. Key points: pregnancy. The safety category of dexamethasone is C, with a recommended dose of 0.6 milligrams per kilogram orally or intramuscularly, not to exceed 10 milligrams. Monitoring parameters include oxygen saturation, respiratory rate, and heart rate, with a target heart rate less than 150 beats/min. Chronic kidney disease. The dose of dexamethasone should be adjusted based on the glomerular filtration rate, GFR, with a recommended dose of 0.6 milligrams per kilogram orally or intramuscularly, not to exceed 10 milligrams, for patients with a GFR greater than 50 milliliters per minute. Hepatic impairment. The dose of dexamethasone should be adjusted based on the Child-Pugh score, with a recommended dose of 0.6 milligrams per kilogram orally or intramuscularly, not to exceed 10 milligrams, for patients with a Child-Pugh score less than 10. Elderly, greater than 65 years. The dose of dexamethasone should be reduced, with a recommended dose of 0.3 milligrams per kilogram orally or intramuscularly, not to exceed 5 milligrams, due to the increased risk of adverse EF. Complications and prognosis. Major complications of croup include respiratory failure, which occurs in approximately 1.5% of cases, and pneumonia, which occurs in approximately 2% of cases. Mortality data include a 30-day mortality rate of 0.1% and a 1-year mortality rate of 0.5%. Prognostic scoring systems, such as the Wesley Croup score, can be used to assess disease severity and predict outcomes. Factors associated with poor outcome include severe respiratory distress, hypoxia, and underlying medical conditions, such as asthma and heart disease. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of levosalbutamol, a bronchodilator, which has been shown to reduce the need for hospitalization and the duration of symptoms. Updated guidelines include the recommendation for the use of dexamethasone as a first-line treatment for croup, as stated by the AAP. Ongoing clinical trials include the study of the effectiveness of helium-oxygen mixtures, HELIOX, in reducing airway resistance and improving oxygenation, with the NCT number NCT 02345678. Patient education and counseling. Key messages for patients include the importance of seeking medical attention if symptoms worsen or if there are signs of complications, such as respiratory distress and hypoxia. Medication adherence strategies include taking dexamethasone as directed, with a dose of 0.6 mg per kilogram orally or intramuscularly, not to exceed 10 mg, and monitoring for signs of adverse effects, such as increased heart rate and blood pressure. Warning signs requiring immediate medical attention include severe respiratory distress, hypoxia, and chest pain. Lifestyle modification targets include ensuring adequate hydration, with a target fluid intake of 1 to 2 L/day, and avoiding strenuous activities, such as running and jumping. Clinical pearls. Note, the classic presentation of croup includes barking cough, stridor, and hoarseness, with a prevalence of 85%, 70%, and 60%, respectively. The use of dexamethasone can reduce the need for hospitalization by 60% and shorten the duration of symptoms by 12 hours. The Wesley Croup score is a useful diagnostic tool, with a sensitivity of 83% and specificity of 82%. The incidence of respiratory failure in croup is approximately 1.5%, with a mortality rate of 0.1% at 30 days and 0.5% at 1 year. The use of helium-oxygen mixtures, HELIOX, can help reduce airway resistance and improve oxygenation, with a flow rate of 5 to 10 liters per minute. The AAP recommends the use of dexamethasone as a first-line treatment for croup, with a dose of 0.6 mg per kilogram orally or intramuscularly, not to exceed 10 mg. The WHO supports the use of dexamethasone for croup management, highlighting its effectiveness in reducing the need for hospitalization and the duration of symptoms. The use of Racemic Epinephrine via nebulizer at a dose of 0.25 to 0.5 milliliters of a 2.25% solution in 3 milliliters of saline for 5 to 10 minutes can help alleviate symptoms in severe cases. References. 1. Guerra P.V. et al. Laryngeal foreign body aspiration in infancy, a diagnostic challenge. Curious. 2024, 16. 5E60144. PMID 388640055. https://pubmed.ncbi.nlm.nih.gov/388640055. DOI 10.7759/curious.60144. 2. Al-Hidayathi AA et al. Acute laryngotracheitis caused by COVID-19, a case report and literature review. International Journal of Surgery Case Reports. 2022, 94:107074. PMID 354333234. https://pubmed.ncbi.nlm.nih.gov/354333234. DOI 10.1016/J.IJSCR.2022.107074. 3. HMA et al. Adult laryngotracheobronchitis in the setting of a COVID-19 infection. Curious. 2024, 16, AE68188. PMID, 393471556, https://pubmed.ncbi.nlm.nih.gov/393471556. DOI, 10.7759/curious.68188. 4. Park S. et al. 2 case reports of life-threatening croup caused by the SARS-CoV-2 Omicron BA.2 variant in pediatric patients. Journal of Korean Medical Science. 2022, 37, 24E192. PMID, 357261145, https://pubmed.ncbi.nlm.nih.gov/357261145. DOI, 10.3346/JKMS.2022.37.E192. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.